hypertension, the causes, and the management of pediatric hypertension. So the learning objective, as you know, it would be to define the chronic kidney disease and identify the etiology of CKD. I would talk to you about the presenting features and complications of CKD. And I'll briefly give you an overview of kidney replacement therapy that includes dialysis and pediatric transplant. So if you go to the definition of CKD, CKD is essentially defined as any kidney damage which lasts for more than 3 months, which is characterized by either structural or functional abnormalities of the kidney with or without reduced GFR, which is manifested by either a biochemical derangement or abnormalities on imaging or kidney biopsy. Or if everything is normal, yet your GFR is less than 60 ml, which lasts for more than 3 months, then even that qualifies for chronic kidney disease. Now, if you look at the kidney disease improvement and global outcome guidelines, which were provided in 2012, these further subdivide CKD into 5 stages based on the GFR. And in the early stages GFR of more than 90 is stage 1, between 60 to 89 is stage 2, between 30 to 59 is stage 3, and any GFR of less than 15 constitutes CKD4, 15 to 29, whereas less than 15 is now defined as end stage kidney disease. We don't use the term end stage renal disease anymore. Everything renal has now been changed to kidney to simplify the definitions of renal diseases for common nomenclature. Therefore, it is now called as ESKD. And as you know, this GFR is by the bedside calculation, which can be done with the help of Schwartz formula in children, where K is a constant across all pediatric ages, that is up to 18 years of age. K is 0.413 into the height divided by the serum creatinine. And so in the pediatric age group, we would be using this formula to calculate the GFR for children in a bedside manner. And besides the GFR, the stages of CKD can further be subdivided based on the albuminuria, because proteinuria is also an important risk factor for progression of CKD, and therefore this has been further subdivided into A1, A2, and A3, depending upon whether it is mildly increased, moderately increased, to severely increased. And for this, you require a quantification of urine protein in the form of either a 24 hours urinary protein estimation, but better is to do a spot urine test of protein creatinine ratios, which are on milligram by gram basis. Now, if you just a word about kidney disease and improvement in global outcomes, it's essentially a non-profit organization that develops evidence-based guidelines for renal decreases around the world. And this is the screenshot of the web page of KDIGO guidelines, and there are plenty of guidelines available here. And for those of you who are interested in knowing more about chronic kidney disease in details, you can go through this KDIGO guideline web page, which is freely downloadable. If you look at the epidemiology of chronic kidney disease in pediatric age group, the incidence is about 11 to 12 per million child population from European registries. And from the Middle East and Southeast Asian data, this is almost 3 times higher, that is 38 per million child population. And if you look at the male to female ratio, the condition is more common in males. And most of this data is from renal registries across Europe and United States. If you look at various pediatric chronic kidney disease registry from where we get the data of epidemiology, this is the North American Pediatric Renal Transplant Cooperative Society data. This is the Australia and New Zealand data registry. And we have our own CKD registry of India, though it works intermittently. The first pediatric CKD registry in India was established in 2006, and we have data of about 3 years from 2006 to 2009. And if you look across all these registries, the first registry started to include patients data only from transplant patients, and then they further widened their network to involve patients who had undergone renal replacement therapy, that is dialysis also, and subsequently they have started including children of lower CKD stages also, that is CKD stage 2, stage 3 onwards, but most of the registries give a data beyond CKD stage 3. Now, if you look at the causes of chronic kidney disease, if you look at the data across the American registry, and you also look at the data from the Pediatric Chronic Kidney Disease Registry of India, the commonest cause of kidney disease or chronic kidney disease is structural abnormalities of the kidney or congenital anomalies of kidney and urinary tract. That is the acronym we use, CACUT. And almost half the patients of CKD are constituted by these structural abnormalities, followed by chronic glomerular nephritis. Then you have tubulointerstitial diseases, chronic pyelonephritis, hemolytic uremic syndrome in a small proportion of patients, and others would constitute some things like your genetic disorders, cystic renal diseases. Then you have nephronophthisis, and you have these renal stones, etc. Now, this is a recent paper from a German center where 405 children of Kakut were evaluated. And of all these 405 patients, almost two-thirds of the patients had an underlying renal hypodysplasia. So, renal hypodysplasia appears to be the commonest structural abnormality of chronic kidney disease in children, and roughly half were antenatally detected. And the stages of CKD were higher in boys who were detected antenatally. Now, if you look at the symptoms of chronic kidney disease, in early stages of CKD, most of these patients have only some growth failure and mostly are asymptomatic. Therefore, many of them present when they have already reached to a CKD stage 4 or 5, and this is a major cause of delayed presentation of CKD to our centers. And the commonest findings below the age of 30, below the GFR of 30 ml is anemia, metabolic acidosis, the bone mineral disease, and once the GFR falls below 15 ml, then you start having nausea, vomiting, gastritis, hypertension, edema, CHF, etc. Now, if you look at the presenting features of our own registry, like this is the data from Indian registry, and roughly 25% of these patients were provided from our own center, that is MMC Pediatric Nephrology Clinic. And if you see that most of these patients presented in late stages when they already had sufficient edema, failure to thrive, and acidosis. And only a small proportion had hypertension. All of them do not have hypertension, at least in pediatric CKD. So, what are the investigations that are required to detect chronic kidney disease in children? Well, if you look at the blood investigations, you need an hemogram because almost every child would have anemia, followed by kidney function tests that constitutes your urea and creatinine, sodium, potassium, calcium, phosphate, and ALP to identify any bone mineral disease, venous blood gas to identify metabolic acidosis, a calcium, phosphate, ALP, PTH, and 25-hydroxy D levels to identify the degree of bone mineral disease, and a routine urine microscopy to identify any proteinuria or sugars. Usually diabetes is a very rare cause of pediatric CKD, so we are not bothered too much about the glucosuria, but we are more bothered about the urinary proteinuria because it has a role in further prevention or progression of the disease. So first you identify the proteinuria with the help of a dipstick, and the next step would be to look at the spot albumin and creatinine ratios in these patients, and then you can, if there is a significant proteinuria based on the albumin creatinine ratio. Normally, albumin creatinine ratio of less than 0.2 milligram by milligram is considered to be normal. Any value between 0.2 to 2 is non-nephrotic proteinuria, and any value of more than 2 milligram by milligram is constitutes your nephrotic range proteinuria. So if you are having moderate degree of proteinuria, then you would require a 24 hours protein evaluation in these patients. Other investigations like 24 hours calcium estimation, oxalates, citrates are required only if urolithiasis is present. It is not required for all patients. And amongst the imaging, an ultrasound KUB plays a very important role in identifying any underlying structural abnormality, to identify conditions like posterior urethral valve and neurogenic bladder, an obstructed bladder, vesico-ureteric reflux. Micturating cystourethrogram is very useful. IVP or intravenous pylogram, which used to be done in the earlier eras, has almost been replaced by nuclear scans. We hardly do an IVP to determine the renal function anymore, and most of the time we would end up doing a functional diuretic renography, which with the help of MAG3 or LLEC or a DTPA scan. Whereas a dimercaptosuccinic acid or a DMSS scan is primarily done for visualizing scars. But a caveat about nuclear scans is that while they are very useful in stage 1 to stage 3 CKD, but in higher degree of dysfunction, that is once the patient reaches CKD stage 4 or stage 5, they may not be very useful because the renal function is already quite reduced and there will be no uptake of this renal dye in these patients. Now, CT scans may rarely be required in these patients if you need to look at some calculi, if there is a strong suspicion of renal calculus disease. But while large calculi are often diagnosed on ultrasound, small calculi can get missed, especially the ureteric ones. So for that, you may require cystic disease. To identify, cystic diseases like ARPKD, autosomal recessive polycystic kidney disease, or autosomal dominant polycystic kidney disease, an MRI which does not expose you to the background radiation, the radiation that is exposed to the by the CT scan. Therefore, in such situations, in cystic renal disease, it's not a good idea to do a CT scan. It would be better to do an MRI. Now, if you have a normal looking kidneys on your ultrasounds, or there is only a slight increase in echogenicity and there is a sufficient reduction in GFR, and if there is significant proteinuria, so if you're not able to make a diagnosis based on other investigation, then a renal biopsy may also help in identifying the underlying renal diseases, especially things like FSGS, glomerular diseases, tubulointerstitial diseases, chronic tubulointerstitial nephritis, etc. Now, genetics too have a role in identifying some of the congenital renal diseases like your polycystic kidney disease, the ARPKD, the ADPKD, and then you have the nephronophthisis genetic panel, and these all can be ordered using the next generation sequencing, which hardly takes a time of 2 to 3 days for the identification of the gene defect. Now, when you are doing a renal ultrasound, briefly what you really need to see at. So what all information a renal ultrasound can provide us, it can tell us the size, tell us a lot about the size and shape of the kidneys. As the children are in a growing phase, right from birth till about 15 to 17 years, the kidneys keep growing. So there are different nomograms for renal sizes across different age. And then the echogenicity, normally what we see is that the cortex is less echogenic compared to medulla. But in glomerular diseases, this cortex tends to get more echogenic. And so if you find that they are echogenic kidneys, then it goes more in favor of a chronic kidney condition. Normally, your pelvis and your ureters are not dilated on ultrasound. In fact, ureter is never detected on ultrasound if it is not dilated. So then you can identify that there is either a pelviureteric junction obstruction or there is a suspicion of VUR if you find that there is a dilated ureter on an ultrasound. And then also a word about urinary bladder. Normally, a bladder wall thickness of 2 to 3 millimeter is normal in children. But any wall thickness which is more than 3 millimeters constitutes a urinary bladder thickening, and which may be because of secondary obstruction like PUV, neurogenic bladders, etc. And if there is post-void residue, that is, if your bladder is still containing urine even after maturating, even that means that the bladder function is abnormal. And then you really need to look at whether there is an obstruction or whether the bladder itself is defective. So these are some of the ultrasound pictures that I'll show you. Now you can see some dilated pelvis in this ultrasound. And if you look at this, in the same child, you are also seeing a ureter which is dilated. So a dilated ureter means that the entire system, not just the renal pelvis, the ureter is also dilated. So possibly there is a reflux of urine from the urinary bladder, which is causing all this dilatation. Now, in this child, you can see that the pelvis is grossly dilated, and apart from the pelvis, the major and the minor calyces are also dilated, indicating the degree of, the degree of dilatation, that it seems to be a very significant peripheral dilatation because of some obstruction, probably at the pelviureteric junction. So, an ultrasound gives you a lot of information about structural abnormalities and dilatations of the kidney. Now, when you look at the main job of a micturating cystourethrogram is to identify the lower tract abnormalities, and especially conditions like vesicoureteric reflux, they can be graded based on the ultrasound also. So if there is only the ureter which is dilated because of the urinary reflux, it is grade 1 VUR, whereas in the grade 5 VUR, you'll find that not only the ureter is dilated, but the renal pelvis is also dilated and distorted, and so are your major and minor calyces. In fact, the minor calyces are also blunted. So that means that the degree of VUR or vesicoureteric reflux is very high. So this all grading can be done based on the micturating cystourethrogram. I'll just show you some pictures from my own clinical practice. Now, this is an MCUG of a 2-year-old girl who came with complaints of recurrent episodes of UTI. And when we did the MCUG, as you can see, the bladder wall appears to be very irregular and it is heavily trabeculated. And you can also see that there are grossly dilated ureters along with dilated pelvis and the calyces, etc. So it's a neurogenic bladder which is refluxing the urine and causing major dilatation of the kidney as well. And there was bilateral gross hydronephrosis on the ultrasound. So this is how an MCUG would be helpful to us in identifying the lower tract abnormalities. This is another MCUG. This is from a baby who came with an episode of UTI and sepsis, and you can see that there is a uretrocele inside the bladder. And besides a large bladder and a uretrocele, you can also see the refluxing urine into the ureter. So many of these structural abnormalities can be identified doing an MCUG. Now, this is another MCUG of a child where we were suspecting PUV because of a poor urinary stream. And when we did the MCUG, you can see that there is a dilated posterior urethra. And in this film, you can also see that the bladder wall is also trabeculated, and there is a lot of reflux of the dye into the ureter. The ureter is convoluted and dilated. So this is also indicating a high grade of renal reflux. So, what are the complications of chronic kidney disease in pediatric age group? Well, these are anemia, hypertension, metabolic acidosis, bone mineral disease, and growth failure. And I'll be talking to you about each one of these individually. Now, anemia is almost a universal problem in all patients of chronic kidney disease, but anemia becomes more pronounced once your CKD stage increases beyond stage 3, and any HB of less than 11 gram per deciliter in all pediatric age group is considered to be anemia. So what are the causes of anemia in these patients? Well, an iron deficiency and a concomitant erythropoietin deficiency. As the renal function is lost, the renal tubular interstitium is lost, so occurs a reduced production of erythropoietin, and that contributes to a anemia of renal disease. And CKD is considered to be an ongoing inflammatory process. So an anemia of chronic disease also occurs in patients of chronic kidney disease. Then in patients who are undergoing hemodialysis, there is some amount of blood loss, which results in iron deficiency primarily. Then you can have concomitant B12 folate deficiency. Some amount of hyperparathyroidism also contributes to anemia. And if you have used drugs like cyclosporin, steroids, etc., over prolonged periods of time, like mycophenolate mofetil, even they cause bone marrow suppression and can cause anemia. But then they are rare causes of anemia in these patients. Now, a word about iron deficiency in patients of chronic kidney disease. Well, the absolute iron deficiency occurs because many of these patients who are especially on hemodialysis would undergo repeated sampling. Then there could be blood loss during dialysis, and also we have seen that in uremic milieu, the span of RBCs is rather reduced. From a normal span of 120 days, this RBC span gets reduced to about 80 to 90 days, and this also leads to a lot of iron deficiency. Apart from absolute iron deficiency, functional iron deficiency has also been described in patients of chronic kidney disease, and this primarily occurs because of altered transferrin levels. Absorption of iron is also defective. So both these processes contribute to iron deficiency in patients of chronic kidney disease. So the diagnostic evaluation that you really need to do in these patients of anemia is a complete blood count, a hemogram with RBC indices and a peripheral smear. And you could do an absolute retic count, because if there is a significant erythropoietin deficiency, even your absolute retic count would be rather reduced. And serum ferritin levels, the transferrin saturation levels, and a concomitant B12 and folate deficiency can be identified by doing the levels. Now, all these patients would require iron therapy whenever their serum ferritins are below 100 nanograms per ml and their TSATs are more less than 20%. Most patients of CKD would be started on oral iron therapies, which could be ferrous preparations, which could also be ferric preparations. Only in patients who are undergoing hemodialysis, we use IV iron, which is primarily ferric preparation in children. And so we usually don't use IV preparations in patients who are not dialyzed, and most of the time oral iron does the work, and iron deficiency can be repleted over a period of 3 months. Now, erythropoietin is usually recommended once your iron deficiency has been repleted over a period of 3 months, and yet your HB levels are less than 10, and this is the situation where you need to use erythropoietin. And if you look at the United States data, almost 29 to 48% erythropoietin usage occurs in patients before kidney replacement therapy or dialysis. And 94% of them who are on dialysis are actually also receiving erythropoietin. But if you look at our own figures from our Indian registry, less than 10% usage of erythropoietin. And the primary reason for this is that the lack of, because of the financial reasons, because while it is available free of cost in our hospital, at most places people have to buy erythropoietin, and that is the reason why it is used less in pediatric CKD in many centers. And the starting doses or the recommended doses of the erythropoietin are 20 to 50 international units per kg per dose, and these doses are provided subcutaneously to these patients. So most of these patients will require these injections twice a week in a subcutaneous manner. In the last few years, a long congener of erythropoietin, that is darbepoetin alpha, is being used very frequently in adult nephrology practice, but it is recommended in children usually beyond 10 years of age. So this can be given every 2 weeks. So that means in every month you just need to give 2 injections of subcutaneous erythropoietin, and the patient would be, like he would be maintaining his HB. So while it is a little more expensive than erythropoietin, but it is much more convenient to use because it can be used every fortnightly. And the target hemoglobin that you want to maintain by giving erythropoietin is between 11 to 12. You don't want to make it extra beyond 12 because there is no additional benefit of reaching beyond these levels, and you will end up giving much more erythropoietin, which will not be very cost effective. Now, what about metabolic acidosis? Normally, when you see that roughly 1 milliequivalent per kg per day of acids are generated by the metabolic processes in the body, and the serum bicarb is maintained usually between 22 to 25 milliequivalents per liter in a normal individual. Now, once your GFR falls below 25% of the normal, almost 43% of these patients would develop metabolic acidosis, which is usually mild to moderate in nature, and it usually happens early in patients who have obstructive or reflux nephropathy because they have an early onset of acidosis due to renal tubular damage. Now, why are we so bothered about metabolic acidosis? Well, studies have shown that prolonged metabolic acidosis leads to reduced albumin synthesis, it causes muscle wasting, and causes a marked impaired growth is also, their growth is also affected. So the recommendation for patients of chronic kidney disease is that we should be giving them oral supplementation of bicarb in 2 to 3 milliequivalent per kg per day in 3 to 4 divided doses, so that we are able to maintain the bicarb levels above 22. And many of these preparations are available now. We have sodium bicarbonate tablets. We also have a sodium bicarbonate powder. We have nodosus syrup, which now can be used in young infants also. And persistent metabolic acidosis has also been associated with worsening of the stages of CKD. CKD progression also occurs because of that. So therefore, it is very important to look after their acidosis as well. So now we used to a word about bone mineral disease of chronic kidney disease. Well, we don't use the term renal osteodystrophy anymore. And the new definition of bone mineral disease says that it is defined as either one or in combination of these. And this is an abnormality of calcium, phosphate, PTH, or vitamin D. Now, if you look at patients of chronic kidney disease, because of CKD, most of these patients will accumulate phosphate because tubular reabsorption of phosphate is secretion of phosphate is impaired, and because of that you will have hyperphosphatemia in higher stages of CKD, and this will lead to concomitant PTH activation, and it would also lead to a lowered calcium absorption, and a calcium overall calcium gets reduced because of this. And also there is a concomitant vitamin D deficiencies. You know that 1-alpha hydroxylation takes place in the renal tubule. So once you have a sufficient renal damage, the 1-alpha hydroxylation will not occur, and because of this will also cause a reduced absorption of calcium, and it will also be a trigger for increased PTH secretion. So most patients of CKD will have hyperphosphatemia, hypocalcemia, hyperparathyroidism, and low vitamin D levels. All this leads to an abnormality in bone turnover, mineralization, and this also leads to rickets in small children. And sometimes vascular and soft tissue calcifications can be observed in these patients when you supplement them with a lot of calcium containing phosphate binders, and this, however, occurs over prolonged periods of time, usually in adulthood. So the bone lesions which occur in patients of chronic kidney disease are primarily due to excess PTH secretion, which leads to an increased activity of osteoclasts, which leads to bone resorption, and you can have really painful bones. And many of these bones are also prone to multiple fractures. We see patients coming with bad fractures, especially femoral fractures, especially in late stages CKD, untreated CKD stage 5. Then defective mineralization, as I said, in children leads to rickets, and in older children it can lead to osteopenia. And if you use your vitamin D and calcium supplements very aggressively, it can actually suppress your PTH also, and over suppression of PTH can result in an adynamic bone disease, which in pediatric age group can result in severe growth failure. So you have to be very cautious about the doses of vitamin D that you are using. So the workup for bone mineral disease, which I said earlier, was that you would basically need the levels of calcium, phosphate, ALP, and PTH, and you also need 25 hydroxy D levels to identify any concomitant vitamin deficiency in these patients. An X-ray of the pelvis and wrist with hand will tell you about the degree of osteopenia, osteodystrophy, and also will identify any rickets in younger children. And it is recommended by the KDIGO guidelines on CKD that this monitoring of these values should be done in early stages every 3 to 6 months, whereas in advanced stages it can be done every 3 months. Now, what is the treatment for this bone mineral disease? Well, if your calcium is normal and your phosphates are also near normal and your SAP PTH are also normal and your vitamin D levels are also normal, you actually require no treatment. But as your CKD stages worsen, it progresses from low vitamin D deficiency to severe hyperphosphatemia and hypocalcemia and very high PTH values. So at this point of time, you would require some form of vitamin D supplementation, which can be in the form of cholecalciferol. And this cholecalciferol should be given slowly in weekly basis for a period of 10 to 12 weeks. Whereas if you find that your phosphates are really high, then what you would require is that sometimes you require dietary restriction of phosphates, and you would require phosphate binders, which are usually calcium containing binders. I'll be showing that to you in the next slide. And you would also require some active form of vitamin D, that is 125 dihydroxy D or alpha hydroxy D, so to suppress your PTH, because overactivation of PTH can also lead to a lot of bony abnormalities. So what are the some common phosphate binders that are available to us? We have both acetate and calcium, acetate and carbonate containing calcium binders. And if you look at the binding capacity of calcium acetate is the best. But if you look at the cost of calcium carbonate is roughly 1/5 of that of calcium acetate. So therefore, in clinical practice, because it is freely available in the hospital also, we tend to use a lot of calcium carbonate for treatment of hyperphosphatemia and hypocalcemia in these patients. And some of the vitamin D analogs like rocaltrol, alpha hydroxy D are available to us in the hospital, which we use for their PTH suppression. Now, the target PTH values usually for early stages of CKD are normal values. You want to maintain the PTH at normal values, but in higher degree of failure, that is CKD stage 4 and stage 5, you don't want to over suppress the PTH also. So if your PTH values are about 5 to 6 times the upper limit of normal, you are okay. You need to suppress it beyond that only if the values are above that. A word about the growth failure of chronic kidney disease, which is contributed primarily because of poor appetite, which occurs because of the uremia. Then there is concomitant anemia, acidosis, and hyperparathyroidism. Then increased protein catabolism because of acidosis. And studies have shown that there is also these patients become their peripheral growth is also affected because of a relative GH resistance in these patients. And in our own clinical practice, we find that more than 50% of the patients, at least who are attending our pediatric nephrology clinic or for most of the Indian centers and government hospitals, are actually malnourished. So the parameters that need to be evaluated for their dietary assessments are essentially, ideally, you are supposed to take dietary assessments for 3-day dietary record, which includes two weekdays, whereas one weekend day should also be included. But this is really difficult to do in a busy OPD. Each dietary assessment would mean at least 30 to 45 minutes time. And to do a 3 dietary records over a week's time, calling the patient again is not very easy. So therefore, what we usually do is we do a single 24 hours dietary recall. And the best way probably to look at the growth assessment objectively in a cross-sectional design would be to look at the anthropometry, the height, weight, the weight for height of these patients, which will tell you that what is happening to the growth of these patients. And this should be done at least every 6 months in these patients. And if the patient has severe growth retardation, they require more nutritional counseling, then they can be called every 3 months for nutritional counseling. And at that point of time, you can assess their 24 hours dietary recall, and also you can look at their anthropometry. Now, a word about pediatric CKD. Now, if you would have had a talk on adult CKD also. Now, while we tend to restrict proteins in patients, adult patients of chronic kidney disease, there is no evidence that restriction of diet in pediatric patients actually improves the outcome. In fact, they land up with a lot of bad growth failure if you restrict their diets. So, all these patients should be given 100% of their RDA for both calories, for macronutrients, for proteins and vitamins and minerals, unless until they are malnourished. If they are malnourished, then they'll require larger amount of calories, and also the protein will also have to be increased to up to 1.5 to 2 gram per kg per day, depending upon the degree of malnutrition. And the patients who are on hemodialysis or peritoneal dialysis, they have a significant protein loss in dialysis fluids, and for this they have to be compensated by additional doses of proteins. Now, regarding vitamins and minerals, as you know, in chronic kidney disease, the GFR gets reduced. So, if you give too much of water-soluble vitamins, even they will not be excreted in urine. So, it's a good idea to give only 100% of the RDA for supplementation, unless until there is some deficiency. Otherwise, it will precipitate toxicity. Now, a word about the restriction of potassium and sodium. All patients of CKD do not require sodium and potassium restriction. Sodium restriction is required only if the patient has hypertension. And potassium restriction is required only if the patient is in CKD stage 4 or 5. That means a GFR below 15 ml. Above that, the hyperkalemia does not develop. So, as a blanket treatment to all patients, the potassium should not be stopped, and it should be stopped only once the GFR falls below 15 ml. And if the hyperkalemia is very significant, if the significant hyperkalemia develops, then in such situations you would require some binders like calcium and sodium cakes. And then if the hyperkalemia develops, then possibly now this is an indication to start hemodialysis or peritoneal dialysis, and this is the point at which dialysis should be begun. Now, hypertension is present in almost 50% of the patients with CKD, although if you look at the data from India, we didn't find it in more than 10% of our patients. And both blood pressure, elevated blood pressure as well as increased proteinuria are predictors of progression of CKD. So it is recommended that in these patients, you don't need to wait till the 95th centile. If the blood pressures are more than 90th centile for age, gender, and height, you should start antihypertensive therapy. And the ACE inhibitors, as you all know, that they are the preferred agents to modify renal deterioration, and they also have antiproteinuric effect. But a word of caution about the use of ACE inhibitors and ARBs, that they should not be used when the GFR falls below 30 ml, because they can aggravate the ongoing hyperkalemia. They should be used only once your GFR is more than 30 ml. And the other antihypertensives that we can use are the calcium channel blockers like amlodipine. We have beta blockers like atenolol and metoprolol. You have the alpha blocker like prazosin, and central adrenergic agonist blockers like clonidine. And diuretics can be used in patients who are actually edematous and also who have left ventricular hypertrophy. So, in a very briefly, I'll tell you what constitutes kidney replacement therapy. Which we don't use the term now renal replacement therapy. The new term is kidney replacement therapy. And kidney replacement therapy can be provided by doing either peritoneal dialysis or hemodialysis, or a renal transplant is the most definite form of kidney replacement therapy, at least in the pediatric population. Because if it's a 10-year-old child, you want to give him a lifespan of at least next 50 years. If you look at the life expectancy in India, it is around 67 years. So if you're doing a transplant at 10, if you do a transplant at 10 years of age, you want that patient to last for another 50 years. You can't live for 50 years on peritoneal and hemodialysis. If you do multiple transplants, yes, you can survive till that age. So therefore, kidney replacement therapy is one of the best therapy, and it also provides a lot of leverage to the child. He can attend to his normal schooling, normal way of life. So it improves the quality of life as well. So the indications of starting any form of kidney replacement therapy are when your GFR falls below 10 ml. So you are already in CKD stage 5 when the patient is in CKD stage 5, then we start the kidney replacement therapy. But also if the patient is having medically uncontrolled symptoms like intractable fluid overload or hyperkalemia, uncontrolled hypertension, child is already on 5 antihypertensive and yet you can't control the hypertension, increasing hyperphosphatemia, which is causing a lot of PTH elevation, uremic symptoms, and if the child is also having persistent growth failure, despite the GFR being higher than 10 ml, even then some form of dialysis or transplant should be started in these patients. So the kidney replacement therapy modalities, as I said, the current scenario, if you look at the United States data from US, you'll find that larger proportion of patients are on peritoneal dialysis. In our country, somehow, because hemodialysis is available free of cost at many of the public hospitals, and most of the patients, especially the older patients, that is more than 10 years of age, would be on hemodialysis. Now, peritoneal dialysis is a much better modality for pediatric dialysis, especially in children who are less than 10 years of age, and especially in infants, because it can be safely done even in infants. But it is a continuous process and it is caretaker dependent. While adults can do their PD on their own, children are dependent on their parents and caretakers. And what we find in our clinical practice is that after doing few months of peritoneal dialysis, there is a lot of parental burnout, and most of them want to shift to actually hemodialysis, which is intermittent and done in the hospital. So there are pros and cons of each of these modalities, but then in children less than 10 years where there is a problem of vascular excess and all, it's not that easy. Peritoneal dialysis is a better modality as compared to hemodialysis. Now, if you look at the principles of dialysis, they are actually similar both for hemo as well as peritoneal dialysis. The dialyzer membrane in peritoneal dialysis is the peritoneal membrane, whereas the dialyzer is an artificial membrane when we do hemodialysis. I'll be showing the circuits of each of these the later slides. And we know that passive movement of solute occurs across the membrane by diffusion in both PD as well as hemodialysis. And for ultrafiltration, that is for fluid removal, we either do an osmotic ultrafiltration in peritoneal dialysis by adding an osmotic agent like glucose to the dialysate, whereas the driving force is achieved by the hydraulic pressure when we are achieving hemodialysis, when we are trying to do hemodialysis in these patients. So if you look at the delivery of peritoneal dialysis in pediatric age group, now this is the manual peritoneal dialysis, for which you need a catheter access to the peritoneal cavity, you need a peritoneal fluid bag, and you need connecting tubes. And then you also have another bag. Usually you have another bag where the dialysate fluid, once it has stayed in the abdomen, you can put the drain fluid in that. So this is a manual PD that is being done, that has been shown here. But now we have automated cyclers also, which can be used for providing with cycles of peritoneal dialysis, which are automated. You can use an automated cycler for that purpose. And this is very useful, especially in young children where the metabolic rates are very high. So if you look at the types of chronic peritoneal dialysis, you essentially need 3 cycles of peritoneal dialysis during the day, and you need 1 long peritoneal dialysis during the night, so that the children as well as the parents can sleep throughout the night. And 4 to 5 cycles are enough. Whereas in children who want to attend school or they go to college, or if there are issues that they don't want to do a dialysis during the daytime, then you can leave them dry during the day. A small amount of fluid stays during the daytime, and during the night time you do multiple cycles. And when you're doing these nighttime multiple cycles, then comes the utility of a cycler, that you can just put in the you can just put the data into that, and if you want 4 cycles, 5 cycles, 8 cycles during the night, and the cycler will do it automatically. So this eases the burden on the parents to do the peritoneal dialysis of the child. Now these are some of the chronic peritoneal dialysis catheters, which are, this is the Tenkoff catheter, this is the straight Tenkoff, this is the curled Tenkoff, or the swan neck Tenkoff that we call as, and they have these two ports, which are, these are the two cuffs. One stays just beneath the peritoneum, and the other stays just beneath the skin layer that through which the catheter would be put. And a significant amount of this travels through the subcutaneous tunnel, so that the infection doesn't progress to the peritoneal cavity. And all these have to be placed surgically. Either they can be placed laparoscopically or by doing a small abdominal surgery. Now, if you look at a typical chronic ambulatory peritoneal dialysis prescription in a pediatric age group, it would be 4 cycles per day, 3 during the night, and 1 during the 3 during the day, sorry, and 1 during the night. And the typical dwell time, the dwell time is the time during which the fluid will stay inside the peritoneal cavity. It varies from 4 to 6 hours in the night to 3 to 4 hours during the daytime. So this is a typical peritoneal dialysis, and you need dialysate fluid volume. This There's no need to go into the details, but you must understand that when we prescribe chronic peritoneal dialysis, the pediatric nephrologist has a role in initiating the process, and also making a plan for the number of dialysis cycle, and also deciding which peritoneal dialysis fluid should be used during the daytime as well as during the night time. Because when you're doing a long dialysis during the night, you would use a higher dextrose concentration so that the dextrose doesn't get reabsorbed once the whole process gets over. For hemodialysis, essentially you need much more expertise. You need hemodialysis machine, you need a vascular access, you need appropriate size dialyzers with tubings, you need a dialysate concentrate, you need an RO unit which you will mix with dialysate concentrate to make large amount of dialysate solutions. Because it's an extracorporeal method, you also need an anticoagulant like heparin during the dialysis process. So for achieving all this, you need trained manpower, not just the nephrologist and the trained resident. You need a dialysis technician and a nurse who would be doing this procedure. Now here this is from our own dialysis unit. You can see a child being dialyzed, and this is the vascular access in the form of a double lumen hemodialysis catheter. This is a dialysis machine. It has two ports. These are actually the two cyclers, and here you have the dialyzer here. And what you can see is that once the blood comes out from the body, it goes to the dialyzer. It is moved on to the dialyzer, and from here the dialysis process occurs inside this dialyzer, and the fluid which is removed from the body is separated out and sent back to the machine, and to the outlet it will go out. Whereas the blood which has been cleaned, that is, or the extra urea, creatinine, etc., and the fluid has been removed, and then this is again, it is sent back to the body from the same side. So from the one single double lumen dialysis catheter, both the in and out as well are happening through this cycle. Now, if you look at, this is a dialyzer, and this is a typical hemodialysis dialyzer, but the dialyzers to be used are different across different ages. And the size of the dialyzer primarily depends upon the surface area of the dialyzer, and the surface area of the dialyzer should be 75% of the surface area of the body. So the small dialyzers, the smallest dialyzer in the Western countries, we have dialyzers even for infants. But in our country, we are usually able to achieve dialysis for children above the weight of 10 kg, hemodialysis. Below that, we tend to do peritoneal dialysis. Now, what is the best site for putting in a double lumen hemodialysis catheter? Well, the best site is your internal jugular vein, which is less prone to infections, and which is also less prone to, and it can be, dialysis through internal jugular vein can be carried easily for up to 3 to 6 months. And next would be, you can use this subclavian vein also. And femoral vein access is usually used only in emergency situations. It should not be for, because once you have a femoral vein access, the leg will have to be non-ambulatory, the child will be non-ambulatory. So therefore, this process is usually used when the patient crash lands with acute renal failure on a background of chronic kidney disease, and it is only for just taking care of the initial 1 to 2 weeks. And after that, once the dialysis has to be established chronically, then you have to put in a catheter in the internal jugular vein. For children who are older in age, that is beyond 10 years of age, you can achieve vascular access by making an AV fistula. These AV fistulas can be made on the forearms, and in a little older children, you can even use AV grafts to create a fistula or a AV graft, from where you can constantly do dialysis without putting these accesses and catheters. Because a major problem of these vascular access is that they are prone to infections. So they can cause repeated infections, sepsis, then they can get blocked at times, thrombosis, and thrombotic events can occur. So there are a lot of complications which can occur, especially with temporary devices. So it is usually recommended that you do short-term dialysis only with temporary devices for not more than 3 months. If you require dialysis beyond that, then you should be using the cuffed catheters, which are placed surgically. Now, a word about kidney transplant. The first successful adult renal transplant was done in 1954 between two twin brothers. The first pediatric renal transplant came way back in 1970s. And you know that after the transplant, most of these patients would require, all these patients would require immunosuppressants. So in the previous before the last 5 years, the immunosuppressants that were being used were prednisolone, cyclosporin, and azathioprine. And over the last decade, there has been a change in the immunosuppressant use. So we use prednisolone, tacrolimus, or cyclosporin, which are our calcineurin inhibitors, and we use mycophenolate mofetil for preventing any acute or chronic rejection in these patients. So, word about the basics of transplant. Well, in most patients, you need a donor who is blood group and HLA matched. And in children, this is mostly the parents. Sometimes grandparents, if they have young grandparents, they can also be considered as potential donors. And the age of the donor is anywhere between 18 to 65 years. Usually, we don't take donors beyond 65 years because the kidney functioning would be poor after that. It would be reduced. So you don't want a reduced functioning kidney to be placed in a child who needs a kidney transplant for fairly long periods of time. And the patient should not be suffering from any diabetes, chronic illnesses like Hep B, Hep C, HIV, or he should not be suffering from active malignancy, the donor. And if it's a deceased donor, that is, if it's a cadaveric donor, then you don't require too much of HLA matching in that case. You just need blood group compatibility. And there is a need for detailed, donor and recipient evaluation. I'm not going into all those details, but these are the basics that you require, not just the blood group and HLA matching. You require to rule out all these diseases. Then you need to know the architecture by doing CT angiography. You would like to know the vascular architecture, because the new kidney is usually placed in the pelvis of the patient and the old kidneys are left as they are. So you just need to connect the ureter to the new ureter to the bladder. You need to connect the vessels also. And most of the time, because the children, we tend to, small children, most of the vessels will be connected to the external iliac vessels, both the artery as well as the vein. So if you look at the outcomes of pediatric renal transplant, now this is the data from US till 2010, and this is the data from many Indian centers like AIMS, St. John, CMC Vellore, SGPGI Lucknow. And if you look at the discrepancy in the numbers, just see the number of uh, transplants which are happening in United States, which has 1/3 the population of ours, and look at the numbers from our country, from different centers. Most of these centers, they end up doing only 5 to 6 transplant at each center, and the primary reason for that is financial resources of the patients are restricted, and again, non-availability of donors, that's another issue. So in most of these series, if you look at the Western series, you'll see that live donation is only in about half. Another half, you have the cadaveric donors. Whereas if you look at the series across India, most of the time it is live donation. And what we find is that is because our deceased donor program is not very well developed. And in most of the time, it is what we find is it's the parents, and of the parents also we find that 80% of the time it is the mothers who are donating kidneys for the children. But if you look at the long-term survival, that is 1 year, 5 year, and 10-year graft survivals, the numbers are similar to the Western. If you look at this 97.9%, 94.9, 89.9, even if you look at data from AIMS during the same period, St. John's, Bangalore, it is similar to the Western data. So the outcomes of pediatric renal transplants are good in our country also. But the only thing is that we need to have a better, probably a deceased donor program, and there has to be some support of financial support from the government to go ahead with the organ donation in children. Now this is just a rough approximation of the cost that is involved in kidney replacement therapy. So if you look at when you're doing hemodialysis or peritoneal dialysis, it's almost similar, except that the cost of hemodialysis is low in government centers because you're not charging them for most of the consumables there. And if you look at renal transplant, while the cost is large in the first year, that is about 3 lakhs in a government center, but after that they have to be on immunosuppression, which may cost anywhere between 12 to 15,000 per month. But if you look at the overall outcomes with prolonged dialysis, maximum one can live for about 3 to 5 years. Whereas with a transplant, it has a graft life, you can have up to 15 to 20 years also. So it is better to go ahead and spend the money through judiciously in a kidney transplant rather than going ahead with only plain dialysis. Now let's come to the other topic that is given to me today, and that is pediatric hypertension. Now, if you look at the definition of pediatric hypertension, till 2017, we were using the 2004 guidelines of pediatric hypertension, but 2017 onwards, there have been new guidelines which have been published and which are much simpler to use. Now, if you go to the definition of hypertension in children between 1 to 13 years, that is between in the pre-adolescent, from infancy to pre-adolescence, we define hypertension as elevated BP when the BP is between 90th to 95th centile for that age, height, and gender. And stage 1 hypertension is BPs of more than 95th centile. And if the BPs are more than 95th centile plus 12, it constitutes your stage 2 hypertension. Similarly, for children above 13 years of age, these guidelines are similar to that of adults. Normal BP is defined as blood pressures less than 120/80, and elevated BP is a diastolic of less than 80 and a systolic between 120 to 129, and stage 1 hypertension up to 140/90, and anything which is more than 140/90 constitutes stage 2 hypertension in the pediatric age group. So these definitions are essentially much easier to use. So you just need to remember elevated BP, stage 1 and stage 2. So every child, when you see his blood pressures, you need to classify whether he has normal BP, whether he has elevated BP, or stage 1 or stage 2 hypertension. Now, if you look at the epidemiology of hypertension in children, less than 5% children would have hypertension, but another 10% would have elevated blood pressures. And there has been an increasing prevalence of hypertension, possibly due to obesity. If you look at the figures of obesity in 1975, it was 0.9%, which has increased worldwide for children and adolescents to about 7.8%, and in some countries like US and in some European countries, it is around 20%. And the prevalence of hypertension in these obese children is roughly 1/4. So therefore, a primary reason for increased hypertension is obesity. And just these are some of the simple charts. Now these are the charts that we are using now for diagnosing hypertension in children. And just let's take an example. If it's a 1-year-old child, and this is for boys, so this is a 1-year-old boy, and if his height is around 80.5 centimeters, 80.2 centimeters, then your 50th centile for systolic BP is 86, the 90th centile is 99, 95th centile is 103, and 95 plus 12 is 105. So on this side, you find that the blood pressure centiles have been given as 50th, 90th, 95th, and 95th plus 12. And on this side, you are given the heights. So if you know the height, or if you know the height percentile, you can use these figures. But most of the time, it is better to do the exact height, and then you can plot it on this curve and see whether the child. Similarly, you have it for diastolic values as well for both boys and girls, and these charts give you a value from 1 to 18 years of age. Now in infancy, we still use the charts which have been provided by the second task force, and here they give you values of 50th, 75th, 90th, and 95th centile, and any blood pressure more than 95th centile, even in children less than 1 year of age, constitutes hypertension. So you can use these charts when you are looking at the blood pressure of infants. Now, word about how to measure BP in children, which is very important to make a diagnosis of pediatric hypertension. Now, earlier, the best way was to use a mercury sphygmomanometer, but you know that for last few years, because of the environmental hazards that mercury causes, mercury sphygmomanometers have been removed, and now we have these non-mercury containing electrical or rather electronic digital meters, which are these sphygmomanometers. Then you have the oscillometry based automatic BP monitors, which actually measures the oscillations within the vessel, and they give you systolic and diastolic values, which is based on an algorithm which has been fed into the equipment. Then you have the aneroid type of BP monitors, which are there to available to you in the ward as well as in the OPD. And the most important part about diagnosing pediatric hypertension is to use an appropriate sized BP cuff, because you'll find a lot of BP sizes cuff which may be confusing to you, but there is no need to get confused. You need to simply remember that you don't need to mug up these charts. If you just know what is the mid-arm circumference of the child, you need to use a cuff width which is 40% of that. So if it's the mid-arm circumference is 14, you need to use a cuff width of somewhere around 6 centimeter. That's it. So this is the only thing that you need to remember. And if you look at the ratio of width to length, it is 1:2. So all these, if you have a width of 6 centimeters, automatically the length would be 12 centimeters. So the recommended devices to diagnose hypertension are that for making a confirming the diagnosis, you should always use a auscultate. It should be by the auscultatory method. But automatic monitors are very easy to use, especially during the pandemic. We have seen that most of the things that we have used in the patients are automatic. So while they tend to overestimate systolic and diastolic BP, but they are very good for screening for hypertension. So they can be easily used in an OPD or the ward for at least measuring the first BP. If you find that it is high, then you can confirm it by using a auscultatory sphygmomanometer. And these are some of the dimensions of blood pressure cuffs that are available to us. So 4 centimeter cuff width is usually used in newborn infants. We use around 6 centimeter. Then you have 9, you have 10 to 11 centimeter sized cuffs, and you also thigh cuffs of which have a width of 20 centimeters are also available. So when you measure the blood pressures of all the 4 limbs, for thighs you will need a wider cuff. You can't use the same cuff for measuring the thigh BP also, because otherwise you will end up overestimating the BP of the lower limbs. Now, so who should be screened for hypertension? Well, the guidelines recommend that all children above the age of 3 years should have at least one blood pressure measured during their pediatric evaluations. But if they are obese, or if they have underlying chronic kidney disease or diabetes, or if there is history of underlying cardiac disease, or if the baby was born as a high risk group, that is preterm, he was stayed in the nursery, required ventilation, etc. So all these children should have a blood pressure measurement at each OPD encounter, or at least during the hospitalization. So what are the primary causes of pediatric hypertension? Well, the primary causes of pediatric hypertension are your renal parenchymal diseases like chronic glomerular nephritis, reflux nephropathy. So most of these would be your chronic kidney disease. And if you look at the causes of renovascular hypertension, it would be your aortoarteritis, you'll have renal artery stenosis, renal artery or vein thrombosis, etc. Rarely, conditions like coarctation of aorta can present as hypertension, especially in infancy and even in the newborn period. And again, endocrine causes of hypertension are rather rare, like with pheochromocytoma, Cushing syndrome, congenital adrenal hyperplasia, primary hyperaldosteronism, even hyperthyroidism can cause hypertension. And rarely, tumors like Wilms tumor and neuroblastoma may also cause secondary hypertension in pediatric age. So if a child presents to you with stage 2 hypertension, it is always a must to rule out at least renal parenchymal and renal vascular causes and see whether the child does not have any co-op. And after this only you make a diagnosis of essential hypertension. So essential hypertension is primarily by exclusion. It is never the first diagnosis in pediatric hypertension. So what we need to do for evaluation, well, all these patients should have a urinalysis and an ultrasound abdomen to to diagnose any underlying structural abnormality of the kidney or any glomerulonephritis. And they would also require an ultrasound Doppler if you are thinking on lines of renal parenchymal disease, because an ultrasound Doppler, if you find that the renal resistive index is increased in the renal arteries, then you can identify, then there can be a suspicion of renal artery stenosis, which can be later confirmed with an MRI angio or a CT angio. But if the child is obese, then you need to do a lipid profile also, an HB1AC also, an ALT, AST levels to screen for fatty liver, etc. So even things like thyroid stimulating hormone, and for FeO you need to look at the adrenergic metabolites in urine and all, also like the urinary VMAs, etc. They are usually required only if there is a strong suspicion of these conditions based on the clinical presentation. Most children of hypertension, if they have hypertension stage 2 hypertension, they would complain of headache, they can complain of palpitations, sometimes they may complain of dizziness, and sometimes they can complain of if it's associated with an underlying renal disease, they may have edema, they may have features of vasculitis. If it's a condition like SLE, they may have joint pain, rash, etc. So it's important to go through the history examination and then decide what are the relevant investigations which are causing hypertension in a child. So as we know that renovascular and renal parenchymal causes are more common, so therefore I said Doppler ultrasonography is a good screening method for identifying renal artery stenosis, but its sensitivity is low. The sensitivity of MR angio and CT angio is almost similar. Till about 10 years back, we were doing more CT angiography, but now we know that when MR angio has a almost similar sensitivity and specificity, it is a good idea to do MR angiography, especially in older children who can hold on to breath and all, rather than doing a CT angio which exposes to a lot of radiation. Now why we are so concerned about hypertension in pediatric age group, that is because of the target organ damage. So, and baseline ECG usually has a poor sensitivity to left ventricular hypertrophy. So we know that hypertension predisposes to left ventricular hypertrophy. So in these patients, it is important to do a good echo, which will look at the left ventricular mass, it will look at the left ventricular wall thickness, and it would also look at the ejection fraction. And it is a must for all children presenting with hypertension to undergo a echo, and this would also rule out your coarctation of aorta. So how do we manage these patients? Well, if the patient just presents with elevated BP and we just screen them for renal diseases and all that is normal, then the first thing that you should be telling this child is lifestyles change. And dietary approaches to stopping hypertension or a DASH diet is essentially what is recommended for most patients who land up with elevated BP or stage 1 asymptomatic hypertension. And these patients would mean that they would need to take a low sodium diet, less of packaged food, etc., and more of potassium containing diet, fresh fruits, vegetables and all, and reducing their weight and decreasing the saturated fats in their diet. And then they should increase their activity. They should not be couch potatoes sitting and just attending all kind of seminars and webinars. They should also go outside and play. And I'm sure that the obesity thing, once these schools reopen, we'll realize that at least 20 to 25% of these children who were actually normal have now become obese. And they also need an adequate sleep to take care of of hypertension. But all these things you can try for a period of up to 12 months. But after 12 months also, if you find that the BPs are still on the higher side, they are still elevated BP, then it is a good idea to do an ambulatory BP monitor and to see whether it is only white coat hypertension or whether it is actually hypertension and it is happening in the night also and in home environment also. And if you find that there is hypertension, then the second level investigations and more detailed investigations should be further done. And the same thing will probably be true for asymptomatic stage 1 hypertension. But if the patient is symptomatic, or even if he presents with stage 2 hypertension and he is asymptomatic, then he should be evaluated and he would require medications. So what are the treatment goals for hypertension in children? We want to maintain their BP below the 90th centile, and it needs to be less than 130/80 in all adolescents. This is for children who are younger than 13 years of age, because the reason being that values above this are associated with higher risk of target damage. And the preferred first line drugs in all these patients are your angiotensin convertase enzyme inhibitors or your ARBs, that is the angiotensin receptor blockers. But a combination of these should be avoided because it can aggravate hyperkalemia in some patients. And calcium channel blockers like amlodipine, as I said, this is the most common calcium channel blocker that we use in pediatric population. And you can also use thiazides like hydrochlorothiazides. And the second line antihypertensive in these patients are your beta blockers, your alpha plus beta blockers like labetalol. Then you have alpha blockers like prazosin. You have central sympathetic blockers like clonidine. And if your hypertension is not getting controlled with all these also, then possibly if there is an underlying CKD and all, he would require dialysis and other things. But then what we generally see in our routine clinical practice, that 2 to 3 drugs are more than enough to take care of most pediatric hypertension in pediatric age group. But we need to find out the cause of this hypertension to ameliorate that cause, because you can't continue these drugs for lifelong. And most of the time, if you identify the underlying renovascular cause, if it's a renal artery stenosis, the child would require stenting. If there is a dysplastic kidney which is not working but it is causing hypertension, it will have to be removed. So one needs to also see that what are the correctable causes. If it is a coarctation of aorta, it has to be repaired. If it is a pheochromocytoma, again the surgical removal of the pheochromocytoma will have to be done and your hypertension will just disappear after removal of that. If it is hyperthyroidism, you need to use antithyroid drugs and treat that. So most of the times you require these antihypertensives only till the time you make the final underlying diagnosis, and once you have treated the underlying condition, you really don't need these drugs after that. So the take home message from this tutorial would be that Caput or congenital anomalies of kidney and urinary tract are the most common cause of CKD in children, and most patients become symptomatic of CKD only once the GFR falls below 30 ml, and an appropriate medical management is usually required till stage 5, after which there will be a need for renal transplant, and peritoneal and hemodialysis should only be used as bridging time or bridging therapy till you achieve renal transplant in pediatric population. And in causes of pediatric hypertension, renal parenchymal and renovascular conditions are the most common cause of pediatric hypertension. I think this is the last slide, and thank you for your patient hearing. If there are any questions on the chat box. So if there are no questions, we can end here. And once we start having our physical classes, then I'll teach you more about these topics. Okay, thank you.